were registering and have to go to something else, but they're coming in later, I think, as well. So there'll be a bit of, it'll be like Lanigan's Ball, where two in a row will be in and out. You know?
That's okay.
So thanks very much to both Sheila and to Angela, Dr. Angela Colquhoun actually, and Dr. Sheila Wickham, both colleagues and friends of the RCSI and the P&A, both ex-fellows, both fellows and both ex-employees, I suppose, at this stage, and happily retired from Dublin City University, DCU, and looking all the better, I might say. One of these, it's a fantastic position to be in, I think, at this point, but equally, we're very grateful that you've joined us today on one of your retired days to share with us. In terms of, there's been a huge interest again in our webinars in the last couple of weeks, and we're very grateful to colleagues for joining us in that space, because it's holiday time, it's busy, and services are very busy. So, but this is a very important subject, and people come back and ask us more and more about Sheila and Angela's presentations over the last 3 years, I think, through COVID, and so Anya and both Paula in our offices had inquiries about both Angela and Sheila joining us again in terms of looking at screening and the intervention and that whole physical health piece in terms of the services we deliver. So you're very welcome, and thanks for joining us this morning, both of you from Mullingar, and I'm joining you from Antrim, and colleagues are joining from elsewhere, so lovely to see you all. And if you don't mind, I'll probably go off camera a little bit. I was explaining to colleagues I'm in a very sketchy internet area, so I'll be there, but I might just come in and out. And I'd pass to you. Thanks, Angela. Thanks, Sheila. And also thanks to Anya for keeping us on the straight and narrow.
Thank you. Thank you very much. Okay. Well, I think we're about ready to start. So, as I said to you, and you probably know before, my background is very much mental health, and my whole area on PhD studies was all to do with the physical health of people, particularly those with severe mental illness. And you know, Sheila is very much, anyone that would have listened to us before is very much into physical health of our patients, regarding particularly huge focus on diabetes and also on cardiac. So we're going to continue on. Those of you who've heard us speak before will kind of know what our emphasis is, always on identifying physical health issues and trying to do something with it. So today we're just going to say why we're screening, and I know at this stage that most of you are conducting some sort of physical health screens on your patients, and you're absolutely all aware of what metabolic syndrome is at this stage, because we've been talking about it for a number of years. So we're just going to talk about briefly why we need to keep screening, but also on what we should be doing to intervene with these patients. And we're going to give some examples probably of how we can intervene and, you know, improve the physical health status of our patients. Just some background knowledge again. Do you remember we've talked about this before, about people with severe mental illness? They have a significant shorter lifespan compared to the general population. And we always have to keep that in our minds when we're meeting our patients, whether they're doing home visits, whether they're coming into a day centre, or whether they're in an acute unit or in a hospital. These patients have a particularly vulnerability as regards their physical health. And although suicide, we know, accounts for 1/3 of premature deaths, only 1/3 of premature deaths in our population of patients, physical health is really responsible for the low life expectancy. And absolutely anybody that has listened to us over the last 2 years will know that cardiovascular disease is the main cause of death in our patients. And we know that men, and also women, but particularly men with severe mental illness, particularly those with schizophrenia, they do have a lower life expectancy of between 15 and 20 years, earlier than the general population. And that's huge concern to us. And we know some of us already have looked at the increased risk of morbidity and mortality in this population, and we know what the causes are. We've gone through these already with you. We talk about the problem with diabetes, the altered glucose metabolism with people, and this starts even in early onset psychosis. We can see 18 to 20-year-olds starting to develop diabetes when they start on psychotropic medication. We know that there's increased visceral fat around the stomach area, and that's why we talk about the need to do a metabolic screen and to know what waist circumference is. We also know that there's rapid metabolic disturbances with specific antipsychotic medications, and that's something that we always are conscious of when we look at medications that patients are on, particularly the antipsychotics, that there is an increased risk of cardiovascular issues and increased likelihood for people developing obesity in that population. We know now at this stage screening is essential, and we know now that nearly every mental health centre around the country in Ireland are screening. They are looking at patients' physical health status, and they need to keep doing that. But screening is definitely not enough. We know now that we need interventions to improve physical health. It's okay to say I've screened the patient and they've got 3 or more risk factors. That's a red line for us. But what we're going to do about it is important. We know particularly for chronic illnesses such as cardiac and respiratory disease, and a lot of our patients already have cardiac issues. They have high blood pressure. A lot of them also have respiratory issues, maybe even COPD. So we know that's already there, and it's a complicating factor when we look at physical health. We know that there is a high incidence, and that's why I'm lucky that Sheila is here with me this morning to talk about some maybe rehab issues around cardiac and respiratory disease that should be able to give us more insight into what can be done for people. And we know that people with mental health problems are, more vulnerable than the general population for these issues. Screening criteria, we've done this over and back a few times. Most people would be using the Alberti et al. Criteria, which is waist circumference, which would be high density lipotropins, which would be increased blood pressure, and would be the fasting blood sugar. So we already have, and I think most of you already have good metabolic monitoring tools that are using, and nearly everybody would be using an evidence-based tool, which will be based on any one of the criteria you see in front of you. We use the European level for waist circumference for our population, which is a waist circumference of 102 centimeters for males and 88 for females. And I won't go through all the criteria because you can look back over the slides and see the criteria that are there, but most of you will already have developed your good tools that you can use for screening these patients. So we won't spend too long on the screening tool because we want to talk about intervening today. Again, I already mentioned cardiovascular risk factors. They're very high for people with mental illness. And I would have been reading this Mark de Hert. He's a Dutch psychiatrist, and he, with a lot of other colleagues across Europe, would be writing about this risk factor for the last 10 years. And even back in 2011, and I think stats haven't really improved much since this. In fact, it may even have disimproved. We still have high rates of tobacco smoking in the population of patients with severe mental illness. We know we have a lot of physical inactivity, and it's one of the things we look for now in our audit tools is to see how much activity our patients are taking. We know also that we have high obesity, up to 50% obesity in a population of patients, particularly those with schizophrenia. We know we also have up to 50% of people with hypertension, high blood pressure. Diabetes is also a problem for us, but mostly type 2 diabetics. And the dyslipidemia is the altered fats within the body. We still have issues with that. So all of these criteria are also, the risk factors are really high, particularly with schizophrenia, but we also have it with bipolar affective disorder, with people with chronic illness. So, these stats aren't improving. I look at the literature regularly, and I see in the literature now that metabolic syndrome is still sitting at around 60% in any sample that's taken, particularly those with chronic illness. When you see a sample of 300 or 400 patients that have been audited for metabolic syndrome, they're coming up with at least 50 to 60%, which is really too high. It's half the population that are being monitored that have metabolic syndrome. And once you develop metabolic syndrome, that's a red card straight away, because there are 3 at least huge risk factors, for cardiovascular disease and for chronic ill health. So we have to be conscious of that. And these are our population patients that we are looking after. So we need to look at more cardiovascular interventions for these patients. And most of that Sheila will talk about is diet and exercises. But the interventions we should carry out will be based on the risk that the patient has. So the risk factors, again, will be 3 or more of the risk factors that we have identified. We look at smoking, obesity, hypertension, altered blood glucose and lipid levels. And they will be, if they're risk factors coming up as high risk, then those patients will need huge interventions regarding dietary and lifestyle advice. You know, and it's all right to say we're doing it. We really have to document it. We have to show evidence of doing it. So structured interventions really are essential here if we're looking at interventions at all for these patients, considering the high risk they are. So most of our targeted intervention will be to do with diet and exercise. And I suppose I caution also the need for medical investigations. We can't do everything. We're not trained to do everything, you know, we're not catch-all. So we just have to do what we can regarding the risks that we see in our patients. So I'm going to hand over to Sheila just to give us a little bit of an idea of cardiovascular and pulmonary rehabilitation, what it's all about.
Good morning. It's good to be, I was going to say seeing you all again, but in touch with you all again. We don't have your cameras on, so don't worry about that. I'd say Angela and myself, as you know, at this stage are a bit passionate about this thing. And we always talk about the screening, and obviously there's no point in screening unless you do something. And the next thing is you intervene. Now, intervention is lovely. It sounds great and we should all be doing it, but it's not easy. And to continue to do it is the biggest challenge. And I think that's one of the things to remember is you don't just intervene once, you have to keep intervening. And if you look at your Leicester tool or whichever assessment tool you're using, there is room for monitoring on that. But the thing is, if I keep monitoring and I see the BMI is not improving or not, or in fact getting worse, then it may require further intervention. And the thing is, we're all busy, and I appreciate where you all are at the moment. You're short-staffed, there's a lot of pressure on, and I'm waffling on about you should do more. But remember, you don't do this by yourself, and that's partly why I'm starting, you'll see, with the word on pulmonary and cardiac rehabilitation. I'm starting on the official ones, the ones that are in the hospital. Interventions cannot be done by an individual. It has to be done preferably with the patient to begin with, and after that, with the support around. And there is support, and we've mentioned QUIT before, but also there's specialist nurses. We're on the increase. There's a lot more. There is pulmonary nurses, there's cardiac nurses. Use them. And it's very easy to dismiss patients with mental health illness, and it's one thing I get cross about. So I would say you have to advocate so much for your patients. What is pulmonary rehabilitation? And this is a multidisciplinary program of care for patients with chronic respiratory impairment that is individually tailored and designed to optimise each patient's physical and social performance and autonomy. Now, as I say, the key word is multidisciplinary. There's no point in you trying to do this by yourself. You have to involve the patient. Quite often, the pharmacist might be involved. Obviously, those looking after their psychiatric medications, but also those who look after their pulmonary medications. And it's interesting because I've seen patients who turn up in the general hospital with a respiratory problem, and all the people there are prepared to do is look at the pulmonary problem. They're going to ignore the fact that they're on medications which are contributing to weight gain or whatever, which is also impacting on the pulmonary. They'll only look at their own area. I've heard that said before as a Newman quote, specialism is the greatest form of selfishness. And that is so true, and we see far too much of it. Mm-hmm. So it is something to remember. And as I say, unfortunately, it requires a lot of effort. The reason we will like pulmonary rehab and think it's important is it will improve respiratory impairment. It helps you diagnose lung conditions, and particularly if they're worsening it. If a patient is concerned about breathing, and I don't know how often any of you have ever had that experience of not being able to breathe, try drowning or trying to drown in swimming, that you can't get your breath, it is quite terrifying. And you can imagine your patients, they have enough complex worries at times, so therefore that they don't want another fear on top of it. Obviously, if you don't have your rehab, you'll become more inactive and more immobile. That'll generally lead to a worsening of your obesity or whatever. Muscle weakness, because if you don't use it or lose it with muscles as well. Reduced exercise tolerance, decreased work capacity, and increased shortness of breath. So these are the things, the reasons I want to do pulmonary rehab for everybody. And their benefits are the direct opposite. But the thing I think to be important, but as you improve your rehab, your pulmonary function, people will generally start moving and exercising, and it improves their quality of life. They also get greater belief in themselves, and these are things that you want to give your patient. And as I say, when I talk at the end, when I talk about the day-to-day things we can do with them, you'll realise how important it can be and how much a difference it can make to your patient. So who should have pulmonary rehab? Anybody who has symptoms and which result in disability. As I say, sometimes can be counteracted if they have unstable cardiac conditions or angina, but they're the outliers by and large. Cardiac rehab is something else, and as I say, it's quite a comprehensive program. It's actually done at 3 levels, and I'll talk a bit more about that now. But it's, again, what I like about cardiac rehab, it's quite a holistic thing as well. It includes everything, you know, obviously the patient, what they're doing, but they talk about weight, they talk about diet, nutrition, about smoking, about exercise. So it's a very encompassing thing. And it does look at the patient as the person as a whole, which I think is very, very important. And as you know yourself, if you only focused on the mental health illness, your patients will not do well. The cardiac rehab, as I say, focuses on the different ones, but it will also include counselling to help relieve stress and such like, and that improves mental health. People post-MI, post-heart attack, are often quite fearful of doing things and get very worried about it happening again. So these are things, again, you consider your clients and your patients. They have enough stress and worry in their lives. They don't need to be afraid of having another heart attack. Cardiac rehab will help alleviate this. Doesn't fix everything, but it'll certainly help alleviate it. This is one slide I wanted to import. Cardiac rehab comes in 3 levels. Obviously, if I arrive in the hospital with a serious cardiac condition, I will get some rehab, my primary rehab in there. As indeed would probably, hopefully, your patients with serious mental health illness would hopefully get at least primary. The secondary is shortly after leaving a hospital, and it's usually for 4 to 6 weeks. Now, I would question how many of you who have had clients who have been in hospital with cardiac conditions have ended up back in the hospital or in a local health centre having their secondary cardiac rehab. And I would just be curious how many of you, because it's a 4 to 6 week program, it's quite interesting. The patient or client turns up usually on 2 or 3 days a week at least. They turn up with their trainers and their gym wear, and they will do a bit of walking, and it's quite individualized. And then the third one is the tertiary, which I can see I've spelled wrong, apologies. And this is longer term in the community. Now, whatever hope you might have getting 1 or 2 of your clients to the secondary one, I don't know of anyone involved in the third. Partly it's not readily available throughout the country, but it is available in certain sites. We had it in DCU. We've now moved it out to the Santry Health Clinic. The HSE were supporting this. And these are people who are not just post-cardiac problems, people who are high risk for cardiac problems are involved in regular exercise. And they get like that. They go in there once or twice a week. They'll have their blood pressure checked and their weight checked on arrival. They do an exercise program which is quite individualized. And now they're monitored. It's quite an interesting program. And I say I know a bit more about it, partly because I was involved in it in DCU. In fairness, it kept about 500 PhD students going. I think there are so many of them, and Andrew will see it there. But it was a very useful program, and it was also very reassuring for people because they would go along overweight. And my own husband, who I sent to it, as you do, after his MI, he was very funny. Met an old friend of ours, hadn't seen for a long time, who had been attending his GP for his regular blood pressure tablets. He was quite seriously heavy with a very overweight BMI, had stopped doing any exercise because of too much effort. His GP retired, the son took over, took one look at him and said, I'm not giving you your medication anymore, go and do this program. And again, it was useful for him because it was a social outlet at this stage. He met people. He realised he wasn't the only one in the world who was overweight, eating too much and not exercising. So it gives them a lot, it gets to be quite a social thing. And you think how much that would do for a lot of your clients or patients. And as I say, how many of them are actually involved in it. Very few. And it's again where we need to advocate, we need to ask, why aren't they? And it's, as I say, it's my argument, they don't see the patient, they see their medical condition more often, and that is important. As I say, when you're talking about rehab, and we always say this multidisciplinary team, the important person on this team is the patient or client. They have to be involved. So you'll have to explain it. To some extent, you have to sell it a bit. So use the language the client understands. Now, you know that ourselves. It's a standard thing, but we have to keep saying it, I think, because we're always teaching you're teaching your colleagues and students who mightn't be as enthusiastic as you, who mightn't be used to listening to it all the time. Explain it as they can understand it. Make sure it's active and realistic. There is no point in suggesting that someone does a couple of lengths of the pool if they can't swim. It's stupid things like that. That's where you have to talk to the client and see what they're doing. Consider sequencing the timing and education. And this is something, so you say it and you say it again and you say it again, and you always have to go back. And I know that certainly for my diabetes education, I was involved with clients. If they were retained 10% of what I told them the first day, I was doing very well. Obviously, opportunities for clarification information. And that applies for you as well as for the client. You'll want to ask them things again. You'll want to ask the rest of the team again and use that. Printed instructions and to reinforce verbal information is very good. I would also say not just print it. Sometimes pictures can be useful. And obviously language this weather, because we have a much more diverse community. Translation is available for an awful lot of our health promotion leaflets and interactions now, particularly from the Department of Health in relation to the healthy eating and the exercise. Yeah. And it's important to remember that. You have to evaluate how it's going. I know your tool allows for that, but you have to focus on, are you looking at it? And where do you stand with it? And obviously feedback to the patient. You know yourself, and we've all had great intentions. I always talk about this. We've great intentions to do things better and do a bit more exercise and all this lark. And we sort of fall off the wagon. So you can imagine if you're working with someone, and I'm sure some of you have done that with exercise that you go out for a walk. If your friend is saying, God, you're really getting better at this, or look how much more you can do now compared to 3 weeks ago. And that's important for your patient or client as well, that you will continue to feedback and say, you're doing well. I know you had a bad week last week, but look how much better you are compared to a month, 4 months ago, 3 months ago. Encourage them to continue. As I say, assess their level of knowledge and build on it. Some people are good at knowledge, and I have a few slides which are quite interesting later in the things, mainly for your reference. I'm not going to go through them individually. On portion control, portion if you're healthy eating. What is a portion? Who knows the official portion of alcohol out of wine? Says herself who drinks, I likes it. It's 125 mils is a portion in alcohol. And how many of us know that? The students certainly never know when I try it with them, or maybe they choose not to, I don't know. But how often do we only pour 125 mils? So it's things like that. Again, you need to know how much does your patient know or understand. You work with the patient as much as possible. Obviously, more updates constantly, and feedback is essential.
Okay.
So I'm going to pass you back to Angela now.
Yeah.
And she'll move on to the start of the interventions.
Yeah, I always say you should probably use the tools that are freely available and at your disposal. And we know before COVID came along, we were trained ourselves to use MEC, making every contact count. And I don't know how far the HSE got to roll it out, because there was a trainer program developed from this. But this tool is actually ideal for us for interventions. It's an ideal tool for us to use to provide health advice and support. And it's something we can document in the ICP to say, we did a brief intervention today and named the intervention, or, we gave brief advice and named advice. It's a kind of a backup evidence-based tool that can be used for us to our disposal, rather than just saying we discussed it with the patient. That's not sufficient. You know, I think if we say we used the contact and how we use the contact, this would be more beneficial for us. For example, you know, the benefits are also, I suppose, that we can find out how much the patient knows about their health. You know, we can explore that with them, what they know about their blood pressure, what they know about their diabetes, you know, what they know about their weight, and maybe develop some ownership with the patient, you know, that it's not just written in our evidence-based tool, that they're aware of it. Because, you know, sometimes we take this information and we develop great monitoring tools or screening tools, but we don't often share that back with the patient. So you're right, it's about giving ownership to the patient. All right, there is a challenge. This takes time. This doesn't happen in a minute or 2 minutes. This can't happen just, you know, while we're giving a depot injection or while we're taking bloods for a Clozaril clinic. This takes a little bit more time than that. This could take 15, 20 minutes, you know. It does need a little bit of space. You can't do it out in a public setting. You need a quiet corner somewhere where you can sit with the patient and have that private conversation. And it also needs you to have some knowledge of how far you can go with your education. So you need some knowledge of what MEC is. But, you know, I can explain to you really the usefulness of MEC is that it focuses on 4 areas. And hopefully, if you're not aware and haven't got the MEC training, that you might speak to some of your managers to say, you know, can I do this training? Because I think it'd be beneficial to me, because it does focus on 4 areas: physical activity, obesity, alcohol and smoking. And those areas are the same areas that Sheila's just mentioned to you when we talk about cardiac rehab or pulmonary rehab. You know, for somebody with COPD, we know that physical activity is a problem, so we look at that. We know that obesity is a problem with those with metabolic syndrome, and we know the detrimental effect of alcohol and smoking and alcohol to patients' physical health. So all of these things we can address. So MEC is really, really useful for our patients to intervene with them, to use as an intervention tool. So I would say use that as your background, specifically with our patients. I suppose we always say, and it's written in every health promotion book, prevention is better than cure where possible, if we can. So if your patients are being screened, and we know they are, we know at this stage, Mental Health Commission are down like a ton of bricks on Regulation 19. So we know you are screening. And we know you're auditing your screening, which is even better. So now I would say we've done the screening, we've screened the patients, we've been doing it for a number of years. Now let's intervene and let's show that we're intervening in our ICPs. Let's document it. So any of our patients that had 3 risk factors out of the 5 that we screened for, follow them up with a health intervention. Show that we have discovered this patient has metabolic syndrome and now we're intervening. Use the motivational interview technique in MEC, because that's what it is. It's motivational interview. It's getting the patient to react and respond with you. Request, you know, this intervention with the patient, 5, 10, 15 minutes. It'll depend on the patient, how quickly they're able to take on board or how often you need to revisit it. Sheila said you don't do it once, you do it at every time, every opportunity. We have to find time to do this because this is so important for the patient. So be seen to intervene, I would say, at every opportunity. You know, make it your business. When your patient's in having their depot, if they've got risk factors, if your patient is in a hostel, make it your business when you're doing your evaluation, because we don't just, you know, assess, plan, implement. We also evaluate. So when we're doing an evaluation with a patient, that's the time to do this, to use that opportunity. And I would say always, always document. If you don't document, it didn't happen. It's kind of useless to you from the backup point of view. We really have to document, and there are rooms now in ICP to document your care. You will find that when a social worker visits the patient, or when the occupational therapist or when the dietitian visits, they will spend as long writing afterwards and much longer than they did seeing the patient. So you need to kind of do something similar. You need to spend as much time as possible documenting the care or the intervention that you've just given. You also have, lots of you know the availability of the HSE on the HSE website, the brief interventions. These brief interventions that I have on the screen now are to do a kind of an assessment of physical activity of the patient, but it also talks about a brief intervention there, and that's based on MEC as well. So we have already documented brief interventions that we can use. So we can use this as a kind of a backdrop. The question is, how often a week do you exercise? And then we get an understanding of what they're doing, and then we can use this as a brief intervention. We can kind of expand on that on our own, as Sheila will show you as we go on. But do use these tools. There's another one there on body weight, and it kind of gives you a good understanding of, you know, what to do when body weight is over 25 over 30, or when it's obesity, when we get to over BMIs of over 30. It gives you kind of a starting point for assessment and for an intervention with a patient. Another one there on smoking and tobacco use, you know, and the helplines that are so available there, signposting the helplines. I don't know if any of you have done the smoking cessation course, but if you had, that would be great, you know, to be able to, you know, use the interventions from the HSE website. That'd be excellent. We're now going to go back, and Sheila's going to start with the first intervention, which is exercise intervention.
Yeah, I'm going to start with, and then I'll waffle on about various interventions for a little while.
Yeah.
And I suppose because my original training was not in mental health, it's something when you become involved in this area, and people talk about serious mental illness. My idea, I suppose maybe it comes from working with diabetes. These are people with serious mental illness. I had worked previously with people with diabetes. But first and off, they're people, and I think it's something we need to keep reminding the colleagues we work with as well, particularly those in the general field who see the illness, as I say, not necessarily the patient themselves. So, to continue. Risk behaviours that contribute to chronic illnesses, and this is what we've been talking about. We're screening for chronic illnesses, particularly, and health risks. Things that contribute to development of chronic illness and the progression of chronic illnesses are lack of exercise or physical activity, poor nutrition, tobacco use, and or drinking too much alcohol. As you see, they are very common with, unfortunately, with a lot of your people with serious mental illness. So, what is physical activity or exercise? Bodily movement involving skeletal muscles. The fitness is a measure of a person's ability to perform physical activities that require endurance, strength, or flexibility. And regular physical activity is a pattern of activity that performed in some order. There's a lot of benefits to being physically active. Controls weight, reduces my risk of cardiac disease, of type 2 diabetes, of metabolic syndrome, certainly helps reduce some cancers. It strengthens my bones and muscles, so there's less chance of you developing fractures later in life. Improve mental health, which is key, and mood, which is ideal for a lot of your clients, again. Ability to do daily activities and prevent falls in the older person, and increases your chances of living longer. So you look at those, there are a lot of good reasons, aren't they, to be physically active. But I also, physical activity, you know, when we look at ourselves, we're not always as physically active as we should be, and yet we stand and preach to our clients. So it's something to remember with it. As I say, we've shown it can help relieve depression and ease it. And actually, in some cases, it can work nearly as well as an antidepressant medication. Yeah. There's short-term, long-term benefits to exercise. From a physical point of view, it can also reduce your blood pressure and reduce the development of arteriosclerosis, which again, unfortunately, a lot of your clients are prone to because they smoke too much, and that also contributes to it. So it does work, it does make a difference. This is key now. If I'm talking to somebody or a patient or client and I'm talking about exercise, again, this is where back to what Angela was talking about, the assessment. What are they doing at the moment? Where can we get to? I don't want to see them running a marathon in October. I don't expect that. If currently they literally don't walk out to the kitchen to get a cup of tea because the wife does it for them, which we'll often find. So what you do is you start it very, very slowly, and you start from where they are. And it's interesting, but it will take months before you'll see an impact. And it's also everybody's normal, so they fall off the wagon regularly on this one. They start well, all enthusiastic for a couple of weeks, and then they're not seeing a dramatic improvement, so they ease off again. So this is something you have to keep working on. And it might be literally this time next year that your patient will say to you, I can actually take the dog for a walk now. And the difference that makes to them. It doesn't have to be 30 minutes a day, it doesn't have to be 30 minutes immediately, and it doesn't have to be complete 30 minutes. I'm happy to start with 5 or 10 minutes with anybody. Fun and enjoyment is important. So even if it's a reward, like if I walk to the shops and buy the paper, then I get the paper, or if I walk, the dog's happy. So it'll depend on what's normal for them. Sometimes it's gardening. If it gets out and walk around the garden and admire the flowers, I'll live with that. Doesn't have to be what I consider fun. You consider day-to-day opportunities. What is available with it? If you consider work, home, leisure, clinic, transport, most people do nothing in any of those domains. So transport, would it be possible to walk part of the journey or even get off a stop earlier? And you think how many of your clients come to you by public transport? Would it be possible for them maybe to get off one stop earlier, or even when they're leaving in the evening to walk to the next bus stop or next? Would it be possible? In leisure, reading a book rather than sit and read it. There's audio books downloadable from the library now. If they're a member of the library, if they're not, maybe they can join and walk to the library. You know, in the clinic, and this is something we did with a few clinics, that they got out for a walk. If they were in, particularly if they were in for the day, they went out for a walk at lunchtime, and that got built into it. And if they're working, walk up the stairs, even walk up one flight. I don't need you to do the 4 flights to begin with, but even walk up one flight, then get the lift. It'll make a difference. So they're simple things, but they would make a big difference to the client. But it's a case of little steps that keep building up. Evaluation, as we say, is essential. Education, support and monitoring. And this is, it's all right. And Angela was talking about the 102 centimetres for the waist. People with mental health illness are not always that well educated. How many of those are in metric? How many of those wouldn't need that in inches? Yeah, 40 inches. Silly things like that. Yeah, well, not silly things, but little things like that can make a big difference. And that's what we have to remember. We talk about stages of change. People are at different stages as well. If you're looking at changing their activity. So you have to remember that. There will be relapses. There will be people enthusiastic. There will be people saying, I'm not prepared to start it yet. You have to keep trying. That's what we keep saying. You have to keep intervening. Key messages are the benefits, the difference it'll make physically, but also mentally. The fact you can do it. I'm here to help you, but you can do it. Social supports. Get the rest of the family involved. And this is again something I've been worked with a lot in diabetes. There was no point in me talking about a healthy eating plan with one person in the family if the rest of the family were going to be busy eating cakes, biscuits, crisps all over the place. We used to get everybody involved as much as possible. Same applies with yours. If both of them, the partner, if there is a partner or whatever, can go for a walk, great. And suggest ways to fit it into daily life. And that's what I mean, that you walk up the stairs or you walk around the garden or simple things like that, just to make a difference. It's one of the 10 leading causes of death and disability in the world. It is an illness in its own right, I would say, but I'm individual there. You'll feel better both mentally and physically. Moderate exercise is better than none. You aim for goals that are realistic, and that's what I mean. If I have someone with a BMI of close to 40 who hasn't moved out of that chair in the last living memory, I'm not going to start. But it's literally, I'll get them walking around the house. I'm happy with it. It also takes a while to get this to be a habit, and that's what I want. I want it to be a salient part of life. I want it to be an everyday part. I'll automatically do things. And it's something we should try ourselves, because it's not easy to do. It'll take a while. It'll certainly take a few attempts. praise them as much as possible and support them, and constantly reassess and monitor. Any exercise is better than none, and just remember that. It's a benefit to all of us. Now, I'm starting on healthy eating. The food pyramid I put up, and this is just a reminder, I'm going to go fairly fast through a lot of these slides because we don't need them in detail, and we'll give you time for questions anyway at the end. But what we particularly note about this, do you remember we used to have the carbohydrates at the end? We changed that around, they're now vegetables, and that I need more fruit and veg in my life. We all need more fruit and veg. And again, you look at your clients who perhaps aren't that well motivated to cook and prepare food. So it's important that you encourage them and educate them in this as well. Yes, you can use help, and this is what I'd be always supportive of. They're stuck in clinic quite often. You will have other talks in or people in. Have you ever considered getting a dietitian in to talk about healthy eating or a healthy eating plan? Sorry, it was, yeah, go back. Just the Irish dietary habits have changed. And if you look at the change over the last 50 years, we're eating a lot less cereals. We're more inclined to eat pasta and things like that. But the problem is a lot of that's too processed and we don't have enough fibre in it. There is an increase, all right, in the fruit and veg. We've improved a wee bit, but we still have over 30% of us not eating enough. Again, we have started eating more fats and things like that, and yogurts have certainly increased, but we are at least moving and looking at low fat, which is progress. We have increased meat consumption, and that's because we're better off, but we don't eat many fish in this country. We still don't. And over 80% of us are consuming more than our recommended allowance on the fats, oils and sugars, processed foods generally. So what's a healthy lifestyle? It's made up of things like healthy eating, a healthy weight, exercise, alcohol in moderation, ideally, smoking, or well, no smoking to be quite honest with you. We have to look at stress and the medications people are on. So if you look at healthy eating, carbohydrate awareness. Do people know what they eat? And have you ever talked to people? It's quite interesting. If you talk to people about what they eat, they'll tell you they don't eat much. Like I had one, they had a decent breakfast and that was all they had. They had just had the porridge at breakfast. Yet the sugars, and this was again by referring back to diabetes, their sugars were going through the roof. But what they were having with their healthy porridge was they had fruit, particularly bananas and grapes. They used to put a few grapes in. And they were also putting honey in and things like that. So yeah, they also put milk on it and a little bit of yogurt. So while we started off with my healthy porridge, by the time they were finished, and that was just pure lack of awareness. Portion control, and we'll show you the slides on portion, a few of them anyway. We eat very big portions, and again, you look at places like McDonald's who are going McPlant or whatever they're doing this weather to be more vegan friendly. But their portions are still exceptionally big. And you even think back to buying a McDonald's portion 10, 15 years ago, there was less of it. We have increased it. Now they've increased in price as well. Being aware of low fat, sugar and salt. Processed foods are generally high in fat, sugar and salt. Like we talk about how much salt is there in, how many slices of bread would I need to eat to get the same amount of salt as a bag of crisps? 5 slices of a sliced pan is equal to a bag of crisps, potato crisps. That's a lot of salt. You look at sugar. If you have a processed pizza, which is very tempting because of fear sandy thrown in the oven, there is a huge amount of sugar in that, partly from the tomatoes and things like that, but there's also added sugar. And definitely the low fat is a challenge. You have to be careful as well with things like yogurts that are low fat, quite often have added sugar because people add for flavour. High fibre, good luck on that. We don't eat enough fibre. We don't eat enough raw fruit and veg. And again, you look at yourselves, you're busy, you're working. How much time do you have to prepare fruit and veg, which is what we need? and what we want. And these are things you consider how challenging they are for you. And I'm asking you now to translate that to an intervention for your clients. It'll take time. And this is where I keep saying you can't intervene once, you have to keep intervening again and again and again. We talk about a healthy weight, 5 to 10% weight loss, and I'll talk a little bit further about that when I'm talking about the amount of calories at the end of my slides. By and large, in Ireland, we are overweight now. We have quite a large percentage of our population, and our children certainly are. So when you consider when you meet your clients, they're usually overweight to begin with. You know how hard it is to lose weight yourself. So it's going to be as difficult, if not more difficult for them. So again, that's where a lot of praise, a lot of education, and a lot of interventions are required. As I say, the physical activity, ideally we do 30 minutes a day, ideally. But as I said, it depends on your patient, depends on your client. I'm not starting them at that. That's what you aim for. And if I get there and it takes me 5 years to get there, that's grand, I don't care. How many of us are physically active 30 minutes a day? It's quite hard. And that's what I'm saying, you talk about little bites of it even and let them build up slowly. As long as they're physically active, I'll be happy. Moderate intensity, and that'll depend very much on your client. It's certainly not where you start. And flexibility and strength. And that's it, well, I don't recommend them fully, even the little yokes. You can sit and pedal when you're sitting watching TV or reading a book. Even that I would consider better than nothing, and it might be an easy way of getting your clients to start. 11 is the measurement for women, 17 for men at the moment. Anything more than 6 units is a binge of alcohol. And as I say, the alcohol unit is our 1.25 ml of wine, a shot, a measure of spirits, a half pint of beer, and there are our units. So how many do you have? And you think of what we do, and then you think of your clients, some of whom would have problems with alcohol particularly, and it's not good for us. Smoking, ideally you don't, and if they've started, get them to stop. We have quit, and this is where I'm use what's available to help you. And if you recommend them and quit as an intervention, then go, have you phoned them yet? How are you getting on? What's happening? Stress and mental health, they're interlinked. I can't have one without the other. And you consider what I'm talking about now. I've talked about the benefits of physical interventions and the benefits of health there. But it will make a difference. But I don't want my client getting stressed that they're not doing all I'm recommending on the intervention. So it's a delicate balance, and one which you'll need to consider. Medication. We've talked already about the problems with the number of their medication, leading to Tourette syndrome particularly. Compliance is a huge issue with mental health, and if I want them to have a healthy lifestyle, I need them taking the right medication in the right order at the right time. Polypharmacy you can't avoid by and large with a lot of your clients. Alternative remedies aren't necessarily available for mental health issues. I know some will believe in them, but they're not readily available. But there may be alternative remedies for some other things and physical things, and the problems with GI disturbance with it. So we have to consider all these things if I'm looking for a healthy lifestyle. As in my healthy eating guidelines, as I move on from my exercise, enjoy a variety of foods, and food has to be fun, and that's what, we do things better if we're enjoying it. So if I enjoy my healthy eating, I'll do better with it. Maintain a healthy weight, 4 or more portions at least, 6 or more of the veg. Fibre daily, and reduce fat, particularly saturates. Fruit and veg are good for you. They will help protect against certain cancers. They can help reduce the risk of obesity and the risk of type 2 diabetes if they're the right ones. And when I say fruit and veg, and again, this is where it comes back to education and education for your client. If I want you eating more fruit, I don't want you eating only bananas, grapes, and sweet berries. I'm talking about a variety. And it's you're also better to take an orange and eat it rather than just drink the orange juice. So it's important you tell that to the client, because quite often they'll try and do what you want, but they might do the easy option. And, you know, again, you consider their dexterity and things like that. Peeling oranges is a pain. Reduce salt, reduce sugar, and keep alcohol. Sorry, they're the old units. I haven't corrected those. Reduce alcohol intake. Let the pyramid guide your food choices. With it, encourage regular intake of calcium-rich food, and that's for your long-term benefits. Increase physical activity. Strict intake of low nutrient beverages. So if you are drinking fluid, that the diet drinks are okay, but too much of them isn't ideal. And a more active role in deciding what to purchase. And again, people with mental health issues can often lack motivation and go fine. Try and encourage them to at least focus on one or two things that they could, and even by being active in that area and fighting for that can help. So portion control, we mentioned it. 1 slice of bread is a portion with it. 2 to 3 crackers or crisp bread. Crackers, when I'm talking about crackers, I'm not talking, you know, I'm talking about the high seed, the seedy crackers and that. 4 of cereal, high fiber cereal, 3 of porridge oats, medium potato. And I'll say the next slides are literally pictures.
Yeah.
So I'm going to go through these because these are more for you to see with them. Just exactly what portions are for patients with it. And they're there for reference more than anything else. It's quite interesting when you talk to patients and clients about healthy eating and just exactly what they do. It's one area you'll find it's useful to get them to keep a diary sometimes, so you get a good idea of what they're doing. And particularly if you're talking about that, even ask them to do it for a few days a week and keep a diary of their exercise and their calorific intake. And it gives you something to talk to them about as well. It's very easy to gain weight, unfortunately, and it's something we have to be careful of. Even just 20 extra calories a day that you don't need will end up getting 2 pounds a year, and that's a stone in 7 years. Now, many of us would limit ourselves to just getting 20 extra calories in excess in a day, and it means it's just so easy. 500 calories a day excess, and a lot of the excess calories, by the way, will often come from alcohol, which is a curse, but it happens. But that's £1 a week you're gaining then. And you'll have a stone on about 3 months. So it's something to remember. First, stop further weight gain. And that's one thing you remember. As I say, I mentioned my patient who's, you know, looking at a BMI of near 40. The first thing I need to do is stop them getting any heavier. And that will usually require some time. And then we'll start talking about losing a bit of weight. Ideally, you do it gradually, and it's all right to talk about 500 calories a day. This quite often will require your dietitian involvement or nutritionist involvement because it's too much. There's too many questions on that, which I must say I wouldn't personally be able to answer without going back and referencing for it. But you do need to reduce calorific intake if you actually want to lose weight, and that's the bottom line. As I say, diaries are handy, but getting active. But then if I'm that heavy and lack motivation, getting active is very hard. And that's where back to the idea of setting realistic targets, realistic goals for your clients with it. They have found that people who eat a healthy breakfast are generally find it easier to cope. What we do have to cut out with our clients, and this can again be hard because if they're sitting around and they're lacking motivation to do anything, it's very easy you get bored, so you eat. Know what their weight is, and how many of your clients could tell you what their weight is. You may record it on the Lester tool, but do they know what it is? And there's no point in you knowing it unless they know it. So focus on that. Obviously, be physically active. And use the websites, health promotion websites. We do have good videos and that. Going to hand back to Angela about the literature. Now we have looked up this literature, so we will have it available for you, and we'll send the links afterwards as well.
Yeah. Thank you, Sheila. Thank you very much. It's always useful to see the pictures of the food intakes and the different amount of calories in each. And I think for those of you who are doing any kind of education in group settings, might be able to use some of those slides, because they give the patient a visual look of. I remember we used to do it with a can of Coke. We found out how many teaspoons of sugar were in it, and we used to get a glass and we used to keep measuring out the sugar and showing them how much sugar was in beside the tin and things like that. And you know, that was very visual for patients, and they really appreciated that, and they kind of, some of them, you know, you could do it over and over again. Maybe with some people you could remind them, you know, do you remember how many spoonfuls of sugar were in your can of Coke? Or, you know, do you remember how much butter is, you know, the allowed daily allowance? And also the one about salt. So there are, those slides, Sheila, are hugely beneficial. You know, they give so much information. And when I looked at the literature around all this area, I did look at the literature. I always look at the literature to see what are the benefits really of healthy lifestyle programs for people with serious mental illness. This particular study that I've opened at the moment, I'll make it available to you. It was done in John God Services, it's Blackrock Services in Dublin. And really what they're looking at here is, you know, running we used to do this years ago when olanzapine came on the market. Those of you who are in nursing a long time like me, when it came on the market, say 20 years ago, we knew straight away once olanzapine landed that there was a huge problem with weight gain. And the olanzapine reps then developed, and well, no, they didn't, the evidence-based people behind Eli Lilly developed a program called Solution for Wellness. And that program was run over 12 weeks, and it was all about healthy eating and diet. And it was back 20 years ago that this started. So we know that these programs have been developed to help our clients to improve their lifestyle and to lose some of the problems associated with obesity. And lots of different studies have gone on all over the world, in Australia and England and everywhere, looking at the benefits of physical activity and healthy lifestyle. And they show how it improves, you know, self-esteem, how it improves, you know, weight gain, it reduces weight gain, but the benefits of nutritional advice and activities. And, you know, the only thing I will say about these studies is they have showed significant improvement, but however, when they go back 6-8 months later, a lot of our patients have slipped back again with more weight gain. So again, the old adage is you have to repeat. So running a 12-week programs, yes, there's huge benefits. But again, and I will make that study available for you to read, to see exactly what they did. And then maybe you might realize then this is something we've been doing as well. You know, we just don't document it. We just don't tell the world, you know, what we're doing. But, you know, the benefits are there. And I know a lot of you who work in hostels or in day hospitals have already been running these type of, maybe not quite 12 weeks, but you've been running some healthy lifestyle programs. And you can see the benefits. But again, it's not once off. You have to repeat them. You have to repeat them in group settings or individually. There's nothing to stop you doing a 12-week individual program of one of your clients. Again, using the motivational interview tools that you saw with MEC, and, you know, the benefits, you know, they should actually be better on a one-to-one than in a group setting, perhaps, you know, but you will know who suits group and who suits individual. You'll know that from your clients. This next one was a piece of literature I came on as well that looked, again, it's all about healthy lifestyle and the benefits of running a program again for people specifically with serious mental illness, you know, because they're the people that we know will have metabolic syndrome. And we know that 60%, over half your clients on your caseload with serious mental illness will have that risk factor, which is a chronic illness. Metabolic syndrome is a chronic illness. That's all you can call it, because that's what it is. And we know that the literature will tell us about how they lowered blood pressure, how the waist circumference decreased, how the patients said had improved flexibility on their walking tests and so on and so forth, a little bit like the rehab programs that you send patients to pulmonary rehab. So they can see the benefits straight away. But the next step was to continue on, to repeat them again, because it does show that these type of studies will only benefit when there's collaboration with other people, not just one member of staff, that there are numerous people involved, because it may need to be repeated over and over again. So the more staff you can involve in running sort of a Wellness for Life intervention program, the better, that there's more sustainability in it, that the patient won't fall off the cliff, as many of us know can happen so easily. Another program there is one that was used, again, nice little read there, metabolic impact of nutritional education and the promotion of fruit and vegetables. And I know you talk about, Sheila, the importance, and Healthy Ireland talk about the importance of promoting fruit and vegetables in the diet, because of the impact of the fruit and vegetables on the good cardio health and on, fibre. And, this study again looked at, always small studies, they're never thousands of people. This only had 74 patients, but it's enough to show, that these 74 people really needed it and the difference it made to them. So I can give you the information there on how it prevents metabolic syndrome in these particular patients with severe mental illness, and how it decreases the likelihood for cardiovascular disease. That's the important message in that study. It decreased their likelihood for cardiovascular disease, which we know will ultimately, if it's not treated and if it's not addressed, can kill these patients. So that's why we have high morbidity and high comorbidities, but also high mortality, because this whole area of cardiovascular disease hasn't been addressed. So this study goes some way into educating us about the importance of nutritional education for patients, so it's hugely beneficial. There's another one here, and this one was, again, looking at activities, a sedentary lifestyle. It's a massive, massive problem. And I know some of you, when you developed your metabolic monitoring tool or your screening tool, you had an area where you filled up whether the patient's actively walking or doing anything. Are they doing 30 minutes a week, never mind a day? So, you're able to monitor exactly what they're doing. So this particular study was just a study that looked at the importance of getting this sedentary lifestyle improved for particularly patients with severe mental illness. And again, the intervention was carried out to show the benefits of a little bit of exercise slowly introduced. But again, as I said to you, like all the other studies, unless it becomes part of the patient's lifestyle, they will fall off again after, they don't particularly want to get up and exercise, bar they're coached as an intervention and bar they're encouraged again and praised for doing that. So that's that particular one. And finally, just one more here. This David Van Camp works a lot with, he's a psychiatrist in, again, a Dutch fella who works a lot with Mark de Hert, who I spoke about earlier, and they spend a lot of time looking at physical exercise again, and the benefits and how to get this up and running for patients. And they talk about the increase in physical activity levels, how it reduces mental health burden, how the exercise intervention can be incorporated into everyday activities, and how the benefits are there. But he does talk about the importance of a multidisciplinary approach to this. It's not just you, the nurse, who are seeing the patient, it's the whole team approach. And when you look at ICPs and you're documenting what you're trying to do with patients, when you're at a kind of a case conference or when you're filling up your ICP, do try and make it known that there are other people that can reinforce this message. Like, as I said, we talk a lot about MEC and motivational interviewing. It's not just for one member of the team to do it, it's for all members, and I know when they rolled out MEC training originally, they rolled it out with pharmacists, with doctors, psychiatrists, physiotherapists, the whole team of people who work in the health service, porters even, everybody. The whole gamut of staff are responsible for helping to give a positive message to patients, so it's really beneficial, they say, to document this, but to also involve other members of the team in the whole area of physical exercise, physical activity, and dietitian and dietary advice. So You know, that's the message. It's a simple enough message, really, what we are saying today. Our interventions, they're not new. You know about them already, but, you know, it's just a matter of maybe getting some props, like the picture props you had there earlier, showing, you know, how much is in all the foods. But, you know, you already have the information, most of you have. You know the importance of the interventions for the patients. It's just making sure that you're visibly seen to be doing it, I would say, and documenting it. They're the big things for us.
Yeah, and we talk about the importance of encouraging your patient and giving them support and monitoring. You need it yourself as well, and perhaps maybe you need to work as a team at times, even among yourselves, that you'll say, yeah, you know, you are doing a good job with so and so, despite the fact you feel I've been pushing water uphill for the last 6 months with him. But it's also, we can get fed up with it ourselves as health professionals. We really feel we're getting nowhere, but it does take time, and we're as human as everybody else.
Exactly.
And it's something we have to remember.
Mm-hmm. Thank you. Yeah. Now we've left a good bit of time for questions and answers. I didn't get to look at the chat box while we were talking, but we'll open it now and we'll try and address it up there. We'll try and address any, or if you can just type in now, if you've waited. Okay. Okay, there's somebody there. There's a problem with logging on, was there? Did everybody get to hear us and log on?
The one thing I would say, the Department of Health, they have a health promotion section. You'll get a lot there on healthy eating, on exercise and weight control. And it's no more than some of you will find these notes beneficial. It's useful then, again, to give those handouts to hand out to clients as well. So that when you're talking about portion control or drinking less or getting out and moving a bit more, use them all the time, you know, because it does make a big difference. And as I say, use your specialist nurses. And just as there's specialist nurses in cardiac rehab and pulmonary rehab, there is specialist nurses in nutrition and healthy eating as well.
Okay.
So use those as well.
Okay. GP involvement seemed to really help with a client I work with. Good. Often they come from the old school of what the doctor says goes. Okay. Yeah.
Well, it's something I would agree, but remember, yes, and they're old school, what the doctor says goes, but you are a health professional too now, and you do have a huge credibility as a nurse, and what you say is considered and will be. The fact you'll say it more often, perhaps, than the GP will work too, because you will get to see them more often, quite often. I certainly would have had a lot better contact with my clients and patients than the doctor or a GP did. Yeah. So that can make a difference too.
Yeah.
And if necessary, get them on board. I suggest you work with a practice nurse. You know, there's lots of ways in there as well to make sure, because the more we can all sing off the same hymn sheet, the better.
I'm delighted to see so many CNS posts in physical health. I think it's well overdue, and it's a fantastic achievement for mental health services to have specialist people there who will make sure that the metabolic screening or monitoring is happening, but also ensure that the interventions for those who we identify with high risk, you know, anybody who has 3 or more risk factors on your metabolic monitoring tool deserve it, because we know if they don't get it, the chance of living over 60 is very minimum for them, because, you know, there's such high mortality, you know. So we have, you know, a great chance now to, and also CNSs, you know, you have a role there in education, in educating junior nurses particularly, because when they come out of DCU or Trinity or whatever college they come out of, they only have a bare understanding of health promotion and they have no experience. So, you know, your role may well be to help, you know, the younger nurses to learn more about physical healthcare, to use the tool properly, the metabolic monitoring tool, but also not to be afraid to be seen to be intervening and to be motivationally interviewing our patients and to be documenting it. Please get them to document whatever their advice are given.
And you can make a huge difference to, you know, your clients, and you know that yourself. And the thing is, so quite often with the best will in the world, we don't have great continuity of care. But the thing is, if I have documented, and Angela goes, oh, and you saw Sheila the last time, and she was talking about exercise or healthy, there's a better chance Angela will bring it up and reinforce the message on the very fact it's written down. Yeah. So it's another reason. personally, I would also say published. Like we were looking at the literature available. There was one good study in Ireland that we found. I think there was a second one as well. But there, we're very limited in what's available. And if you have any experience, share it. Go and present it. Let your colleagues know. And even if it isn't always 100% successful, I tried this. It didn't work very well, so I tried that instead. That's the only way we're going to get better. And if we share our experiences, it does make a big, huge difference, and it makes life easier for my colleagues at work, and it makes life so much better for my patient. And as I say, when it works, you'll find the difference it makes to them.
Yeah.
And it's such a little achievement.
Make a comment, sorry, Sheila, and
Yes.
in terms of the CNS piece, I couldn't agree more. It's great to see so many posts in terms of physical health screening, etc. But again, as Angela said, the role therefore is not just lies with the CNS. It's across the whole discipline and the nursing family, and that role is education. So, what you don't want is an appetite. Oh, we have a CNS that does that, and that's definitely not what we want. So the whole idea is that the CNS empowers the team, underpins with the research that you've shared with us, instructs or informs, I suppose, in a nice way, how to do the tricks like the can of Coke, etc., all of those things, and then to spread it across the whole team, the multidisciplinary team piece, because again, there's a little bit out there, there's a nurse for that. Yeah, there is a nurse for that, but there's a nurse for lots of things, and it's everybody's business, really, if we're talking about multidisciplinary team. And just one other thing, and it's a while since I worked clinically, as you know, but and actually this is interesting in itself, because we're going back to the early 2000s, and I was working in CAMHS at the time, and we had set up a group with the paediatric services where I was, looking at this whole physical monitoring piece for young children, because issues regarding obesity, etc., was becoming a big issue. And this, now I'm going back to the early 2000s, when it was identified at that point that we need to do something about this. So our CAMHS service was seen as a good mechanism, along with the paediatric team, to kind of conjointly work with individual parents and families, where this was becoming a problem. So again, it's not just about the adults, it's young children and young people, and these tricks, or I suppose collaborations, are really good in terms of working with other disciplines and other services, really,
Yeah, for sure. Yeah. But I think, Aisling, we've come a long way in 20 years.
Yes,
and I can see huge improvements in our services in 20 years. And we're moving on now to advanced practice, and we have huge role models out there, and very, very well educated nurses, from degree programs and from postgraduate studies and masters and up to PhD level. And we have huge benefits now. People know they know the evidence is there, and they understand it, and they can read it.
But it's a very key point you're making about the CNS. The specialist CNS and physical health is not available 24/7.
No.
So it's important that they're saying, and listen, I've told X about such and such. Will you just check up they still understand it or remember? So it's a case of, and it is the problem about being a CNS. You don't just educate your clients, you have to educate all the rest of the staff as well.
That's right.
That you're a resource there to support them, not to replace them.
Fantastic resource. But I'll finish up my piece and just saying thank you indeed for the wonderful resources you've shared with us as well. We're very gifted and blessed in terms of the up-to-date research and the evidence that underpins it, because every time I come on, I learn something new, and it's thanks to you kind of going back through the literature, looking at the new pieces, even looking at what we said, the triangle has changed. It's hugely changed.
The triangle's changed.
And that's and it just, it's a complete flip around in terms of our thinking. So thank you both again for the resources, along with the practical part of the presentation. I just wanted to say that. I'm sure colleagues may have other things to say. I know there's a lot of thanks in the chat room there to you, but I'll keep out of it for a few minutes in case there's any other questions.
There's the triangle. I just found it there a second ago. The triangle has changed a lot. Look, we're willing to share anything we have. We thank the P&A for making this and the Royal College of Surgeons, because this is what we need. We need little slots where we can be available and where people can log in and see us and talk to us. And, you know,
so we say it's constant interventions and the fact things change.
Yeah.
And you even look at the medications we talked about 20 years ago. The medications we are using now, half of them didn't exist 20 years ago, you know, never mind their side effects. So it's why we always need to keep looking at and reevaluating and evolving basically in what we do with our clients and patients all the time.
Yeah.
It's so hard with it.
Yeah. Yeah. If there's any particular questions about any aspect of the slides, do come back to us. Anya is there in the background taking heed of what's going on here. So, you know, the slides that have the pictures in them, I think, are very relevant. These particular slides here, I think, are hugely relevant.
They're very useful.
I know you've used them over the years for teaching, Sheila, but
I'm looking for the
you
ones
know, portion size, you know, lots of people don't realise what a portion is.
And I say the drink portions are choice. Again, there's a lot of
so I think you could use these. Yeah,
as well for them if they wanted to.
If you want to use these, we'd be really delighted to see these being used hugely across, you know, because people don't realise, you know.
Thanks so much, Sheila and Angela. Yeah, no, I'll send those out. There was 2 queries in there just in relation to previous webinars and certs. I was waiting to hear back from the NMEI just for their approval of the CPD points, but I understand Elizabeth in particular needs these for work. So I will send all the certs out today, and when we get the points, I'll send them out as resend. But with that, I will send these slides because they are, so even for myself, I'm looking at the portion sizes and I know it'll be useful to me. So thank you so much.
Okay, thank you. Okay, well, I mean, we're conscious of time and it's hard for us to engage for an hour and a half, but that's why we try to sort of finish up that little bit earlier to give people a chance to, you know,
question or query.
And also you lose people over an hour. So I'm sorry if we sickened you and we lost you over the hour.
Not at all. Put a whole new slant on my couple of days annual leave, I can tell you, in terms of portion sizes.
But thank you to those who attended, and it's always good to see you there. And I can't see you, but I know you're there in the background. So thank you for taking the time out this morning from your busy schedules to link in with us.
It was good to keep in touch, and I hope
we hope to grow. We hope to grow a few nurses that will take over our roles, because you know we're both kind of retired, so. It's time now we got a few to step up to the plate here and take on this.
So it was interesting because with COVID, I actually spent the last year vaccinating, which is quite interesting from point of view of if you're into health promotion. It was a great time. People would have believed anything I said. And it was quite interesting to talk about, it's not just the COVID, we need to be healthier generally. Oh, yeah. You know, so it was quite interesting to have the opportunity to give that message.
Very good.
A lot.
Very good.
As well.
Yeah.
So you can use any chance you have, basically.
That's your
get the message across.
That's your MEC, yeah. Make every contact count.
Make every contact count.
Yeah, MEC. I'm a believer in it. Yeah, definitely. And I think we know that from our interactions with clients. You know, when we interact so many times a day with a client, that everyone, it's not just talking about the weather or, you know, whether they like their dinner or not. It's much more than that. You know, it's much more therapeutic than that therapeutic interaction. So it suits psychiatric nurses down to the ground, I think, the MEC. It's made for us.
No, you see, I think it suits everybody.
Okay, I bet you do.
That's my argument. We're all people, and including all that. If you happen to have an illness, that's so be it. Okay. But you still need to be minded with it.
Okay. All right.
Thank you so much to you both again, and it's lovely that I could stay joined here. So that's serendipity in itself. To send the message. Thank you for being here, and thank you for being friends as always to the College of Surgeons and the P&A. And we hope to see you maybe after the summer again, if that suits you, wherever you may be.
Wherever we may be. Okay. Thanks, everybody.
Take care.
Thanks, everyone. Bye now. Bye.
Bye. Bye now.
Bye now.
Bye.
Bye.